On behalf of the Patient Safety Authority, I'd like to welcome you to this webinar titled Error and Uncertainty in Diagnostic Radiology. My name is Kathy Reynolds, and I'll be your moderator for this program. A copy of today's slides is available using the link provided in the chat box. The webinar will be available in a few weeks on the Authority's YouTube channel. We welcome any comments or questions, and all materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar, Dr. Michael A. Bruno, Professor of Radiology and Medicine, Chief of the Division of Emergency Radiology and Vice Chair for Quality and Patient Safety for the Department of Radiology at the Penn State Milton S. Hershey Medical Center in Hershey, Pennsylvania. Dr. Bruno's primary scholarly and research interest is in the area of quality improvement and patient safety, with an emphasis on understanding and preventing radiologists' diagnostic errors, as well as the improvement of communication between radiologists and other caregivers. Dr. Bruno has also published several heavily cited articles in the peer-reviewed medical literature on these topics, as well as numerous book chapters, commentaries, and practice guidelines, and he has created several enduring online educational materials for physicians. He is a frequent speaker on radiology quality and safety and related topics throughout the United States and internationally, and his work to improve communication between doctors and patients has been featured in the Wall Street Journal. He is also the author of 4 radiology textbooks, most recently, Error and Uncertainty in Diagnostic Radiology, which was published last month by Oxford University Press. Dr. Bruno, I will now turn the program over to you.
Thank you very much, Kathy. A very kind introduction, and hello, everyone. Today I'm going to focus on error and uncertainty in diagnostic radiology, which is a topic near and dear to my heart, as Kathy mentioned, and I hope that you'll find it interesting, even though I assume that most of you are not radiologists. But radiology touches every specialty of medicine to some degree. Pretty much every patient passes through radiology on their healthcare journey at some point, and so I hope that my comments are relevant and interesting to everyone, regardless of background and subspecialty and that sort of thing. So yes, I'm from the Milton S. Hershey Medical Center, which looks kind of like this. Up in the upper left-hand corner was created as a gift from Milton S. Hershey, who brought chocolate to the world. And that's him in the upper right-hand corner with one of the orphans that he adopted and set up an orphanage, which became the Milton Hershey School, and whose endowment started Milton S. Hershey Medical Center, which opened its doors in 1967. In terms of my own disclosures, this is not a CME program, but I'm going to go ahead and disclose a couple of things. As Kathy mentioned, I'm the author of 4 textbooks. I get royalties from all 4. Here's 3 of them are shown here. And I used to be a shareholder of Hershey Foods, so if you've enjoyed Hershey Kisses and chocolate bars and Kit Kats and Reese's Peanut Butter Cups, I just want to say thank you very much. Today's focus is going to be on error and uncertainty in radiology, and what I'm going to say overlaps a great deal with the recent book, which was just published last month, and so I'm going to be referencing a lot of material from that. Our objectives for today, we're going to really focus on perceptual error, which is the #1 type of radiologist interpretive error. And I'm going to discuss the overlap between error and the underlying high level of uncertainty which exists in radiology practice. And I'm going to present a 3-part error model, which I'm proposing can explain errors and help to focus efforts on error prevention strategies in radiology, and it might apply to other areas as well. A little philosophy is always helpful, and every lecturer should have a quote from Goethe, and he said, "It's easier to perceive error than to find truth, for the former lies on the surface and is easily seen, while the latter lies in the depth, where few are willing to search for it." And of course, Albert Einstein commented on this also. He says, "As far as the laws of mathematics refer to reality, they are not certain, and as far as they are certain, they do not refer to reality." So uncertainty is a fact of life. In radiology, we operate in an environment of extremely high uncertainty and actually fairly high stakes, to a degree that people in other walks of life might find to be fairly paralyzing. high level of uncertainty, and inaction is rarely an option for us. And what this means is that we're reliably going to make errors. And others may suffer from our mistakes. So it's a very serious business. So I want to give a brief review of, there are multiple types of error that can occur in practice. This is practice of all kinds: systems errors, communication errors, cognitive errors where we think through things wrong. There's random errors, which we're all very familiar with, and of course perceptual errors, which are the largest type in radiology. So why are perceptual errors so important? What makes them different? Well, I think that human perception is really the final common pathway in a lot of areas in medicine. Certainly pathologists looking in the microscope, endoscopists, dermatologists, surgeons, but even things like airport security screeners and people who look at satellite intelligence and fly drones and decide what things to blow up and what things not to blow up. Ultimately, the human perception is what decides all these critical things. So we have to take a closer look at that. I think this is a familiar scene that all of us have been through airports, and we've observed the TSA screeners. And I'll point out on this picture is a very, very busy scene in an airport. And in the lower right-hand corner, you can see a lady sitting in front of two computer screens. That's the TSA screener. And she's looking at radiology fluoroscopic images of the luggage as it goes through the conveyor belt. And as you can imagine, she's working in a very different situation than my reading room. I have a quiet room. Sometimes we have a little classical music playing softly in the background, and the lighting is optimized, and I'm sitting in a very comfortable chair, and my temperature is controlled, and I have my cup of coffee, and you know, my perception is pretty optimized to the extent that it can be. And you know, she seems to have a very different situation, work environment than I have. And yet she's trying to do a very similar task to what I do every day. And as you might expect, there's a pretty high error rate. If you look at this, this is an X-ray of a bag. In the lower right-hand corner of that black and white image, you can see something that looks kind of like a knife blade. That's because it's a weapon. And it turns out that TSA screeners miss between 70 and 90% of weapons. They do, however, pick up pretty much every water bottle. So don't try to smuggle a water bottle onto an airplane. You'd have better luck getting at your weapons in. Why is that? Well, there's a low target prevalence for weapons. Very few pieces of luggage actually have a weapon, whereas quite a few have a water bottle. So there's very high target prevalence for other prohibited items. And so they get very good and very experienced at detecting those things like water bottles, and have a much harder time seeing things that only very rarely appear. And the TSA officers report that it's difficult for them to remain vigilant, and you can imagine in that chaotic situation in which they work. And the error rate that they have, it persists despite introducing terrific technology, and they have fantastic training, and these things have been studied. And one thing that has been done to improve their accuracy is, you know, fake bags are periodically put through with fake weapons in them to try to increase the target prevalence to make them more used to seeing things that they don't regularly see. And this is an example of the images they can get with their new gadgets. They can, you know, detect a wad of Kleenex in your pocket. So it's not really the technology that's letting them down. It's human perception and human perceptual error, which is the problem with TSA screening, just as it is for us in radiology. It kind of reminds me of the old joke about, you know, failure of what part of a car is the #1 cause of accidents. I think most of you can guess the answer. It's the little nut that holds the wheel. In cyberspace, no one can hear you chuckling. Diagnostic errors in radiology. Visual perception and cognitive interpretation are probably our two biggest errors. We know that radiologists' error rate of interpretation is estimated at 3 to 4%. That's been true for at least 5 or 6 decades since it was first measured. The rate is higher. It can be up to 30% if you're only sampling exams with abnormal findings. That's not reality. In reality, radiologists will look at unselected clusters of cases, some of which are positive and some of which are not. There have been higher rates of error for specific modalities in radiology. Chest x-rays are a little higher, CT is a little lower, ultrasound is probably the lowest. And just like with the TSA screeners, the error rate increases when you're looking at exams that have low target prevalence. In other words, if the thing you're looking for is very rare, when it does come around, you are more likely to miss it. I want to give a nod to Dr. Leo Henry Garland, who lived between 1903 and 1966, so he was not alive when the Milton S. Hershey Medical Center opened. He practiced in San Francisco, and he was a pioneer in radiologist error, in the study of radiologist error. And at first, of course, it made him kind of an unpopular guy. But he described the 3 to 4% error rate back in the 1950s. Kim and Mansfield, more recently, published in the American Journal of Radiology and Radiology in 2014, a paper called Fool Me Twice, and they studied the problem of diagnostic error in clinical practice in a very systematic way. And they gave us a very nice taxonomy and epidemiology of error. The reference to their paper is there on the screen. And they also talked about perpetuated errors, in other words, errors that happen more than once. And they found that happened quite a bit. So in their paper, they looked at 656 radiological examinations that had errors leading to delayed diagnosis, and they were collected between 2002 and 2010. And each of these error cases was reviewed by 2 radiologists, and they were classified according to a 12-step schema that Kim and Mansfield developed themselves. And sometimes more than one type of error was assigned, because sometimes more than one kind of error contributed to the problem. So this is their scheme, and what they called it, this is taken straight from their paper. They had their own sort of taxonomy, and it's actually very interesting. So look, I want to call your attention to number 4, error classification number 4, which they called underreading. That's where the finding is just simply missed. And they thought that perhaps it could result from failure to isolate important material or other causes, but number 4 is you simply missed it. I would call that a perceptual error. Number 3 is lack of knowledge. We have a sense that if you don't know about something, that you won't see it. And number 10, I want to point out, is satisfaction of search. This is a strange phenomenon that we see where if there's more than one abnormality on an image, it's quite common for a radiologist to see one of the abnormalities and not the other. And the name, satisfaction of search, implies that the mechanism and the explanation is what Kim and Mansfield thought, which was you don't continue to search for an abnormality after you find one. You're satisfied and you stop looking. But we've actually done research on what happens in these cases, and it is actually not a case where the person is satisfied and stops searching. There's no difference between the length of time the radiologist scans an image in a case where the second abnormality is missed. There's really no difference in their eye tracking patterns. We actually have gadgets that can tell you where the radiologist was looking on an image. We call it eye tracking. And the eye tracking pattern is characteristic for each radiologist, and it doesn't change in these cases. And then the third very interesting thing is quite often the thing that's missed is more obvious than the thing that was seen. So something else is sort of going on with these satisfaction of search errors, but they're very common. And if you talk to people, including radiologists, they'll tell you, oh yeah, that's our big error is satisfaction of search, but it's actually not. Number 8 is history. If you have an inaccurate or incomplete history, you can mislead the radiologist or lead them down a garden path and make them make mistakes, and that's very true. And that's because we all applied some degree of Bayesian reasoning where the pretest probability of disease is, guides us. And if we're misled by the history, or if the history doesn't point us in the right direction, that can artificially alter the pretest probability in our mind, and that can lead to errors. So, number 12 is complacency of report, and they call that satisfaction of report. And that is if the previous study was read by somebody that we respect, we tend to just go along with them and not question whether they were right or not, and that leads to propagation of errors. So that it's not super common, but it does contribute a small amount to the overall problem of error. So let's look at that. They had 1,279 errors in their series in a total of 656 cases. The range of time between when the error was made and when it was caught was quite large, up to 9 years or so, but the average was about 250 days, so nearly a year. 67% of the cases had more than one type of error, and they were distributed. There was a little bit more in plain X-ray than CT, than MR. And notice ultrasound had a very, very low rate of error. We'll get back to that, but 60% of the errors that were discovered were in X-ray, and only 1% were in ultrasound. But they also found that errors were repeated on subsequent studies, 196 times out of the 656 error cases. So that was about 30%, where the same mistake was made a second time as well. And here's the distribution of the error types of the total number of cases. Now remember, number 4 was our basic perceptual error. That's where something is there, and maybe it's obvious in retrospect, but they just didn't see it, and that is by far and away the most common type of error. And then number 10, the so-called satisfaction of search, where you find one thing and don't find another thing on the same image, was about half that, or 22%. And everything else was really a pretty small contribution. I would show you type 3, the type of error where you make a mistake because the radiologist just isn't aware of it, lacks knowledge. That's a very, very small contributor to overall error. And part of that is because radiologists are well trained and they get lots of knowledge in their head, but also it just doesn't seem to be the biggest cause of error. It's dwarfed by perceptual error. And of note, radiology as a field has put a tremendous effort into continuing education of all kinds. Every radiology meeting you go to is full of talks on how to avoid various pitfalls and how to avoid missing certain kinds of things, really chasing that error hypothesis that if you only knew more things, you would make no errors. And it just is not going to pan out. You're not going to be able to fix more than 3% of the errors, at least in the Kim and Mansfield series, by increasing radiologist knowledge. You're still going to have 64% of the errors being made. In cases with only one type of error, the dichotomy is even greater. 70% of those were the simple perceptual errors, simply not seeing something which may be obvious to even the person who missed it in retrospect. So, and the emotion that we have when that happens is like, I don't know how I missed that. It's a tremendous sinking feeling that we get. So in their series, the majority of errors were perceptual errors. The second most common was satisfaction of search. And the third most common was type 9, faulty interpretation, where you see something but make the wrong determination of what that thing means. So here's an example of a perceptual error. And take a look at this chest x-ray of a child. You see anything that shouldn't be there? Right, there's a swallowed coin. You have to look right through the heart to see it. It's in the distal esophagus. And I think it's not all that difficult to see, but it was missed twice by skilled pediatric radiologists. And when it was shown to this person, they said, wow, I don't know how I missed that. It's so obvious. That's a typical feeling that we get when we find a perceptual error. Similar results in other studies. There was a study by Jennifer Donald and Stuart Bernard back in 2012. They also had a similar size of their study, and in their series, 80% of the errors were perceptual errors, and approximately half of these were considered to be non-subtle on retrospective review. And Kundal in 1989, Siegel in 1998, Revez in 1997, and Queckel in 1999 all had similar results. And if you want to look them up, you can. All the references are here. So most radiologist errors are due to failing to perceive abnormalities which are sufficiently conspicuous, sometimes even obvious in retrospect. And of course, it would be really nice if all patients came with their films labeled like this, with nice arrows and words right on the cancer showing you where it is and exactly where to look, and telling you which lung was the left lung and which one was the right. This is really nice. So patients don't come labeled, unfortunately, but we're working on that. So perceptual errors, they're poorly understood, And for this entire class of error, the only thing that ever seems to work is double reading. That's been the only effective strategy since the time of Garland, and Garland himself advocated it in 1956. And remember we talked about the relatively low error rate in ultrasound, why it's so different from all the others. Well, it turns out that in almost every practice, ultrasound images are all double read, and that's because the ultrasound technologist, the sonographer, is a very skilled person who does the scan and sees things, and then the image is second read by the radiologist, so they all have double reading. And I think that explains why ultrasound is so much more accurate than every other type of study. We don't have routine double reading on anything other than ultrasound. In some countries, they actually have double reading of mammograms, but we don't routinely do that here. But you know, it's a powerful thing. One place where we do have double reading is in academic centers where residents do after-hours interpretations independently, and then their work is checked the next day by an attending faculty physician. And in that case, we have double reading. And in our center, like most academic centers, the faculty read a lot of cases without a resident, and they also read all the cases that the residents interpret. And that's part of the teaching process. The residents make interpretations, and then we check their work, give them feedback, and that's how they learn. And you know, they after hours they have some autonomy with that, but during the day we double check them pretty quickly. Well, Balthazar studied you know, the performance of this and what it did for error reduction. And when an error is found on a radiology report, the typical thing that's done is we put an addendum on the report. We don't change the report. We preserve the original language of the report, but we add an addendum to it. Usually it's printed right at the top saying, well, actually that wasn't correct. There is something, you know, or whatever the error was. So if you use electronic systems to track the number of addendums, you're basically tracking the number of errors. And what we found was that if there was a trainee involved, there were a lot less addendums, because in those cases there were double reading, and the effect was 12-fold. Your report was 12 times more likely to require an addendum, which is a good proxy for error, if it was generated by only one person than if it was a double reading. So we concluded from this study that double reading may provide as much as a 12% benefit to accuracy. That's a lower end estimate. It may even be greater than that. So one way to accomplish double reading is using artificial intelligence. And you may recognize this. This is the map of a neural network convolutional deep learning artificial intelligence model, where you have an input layer of software and it goes to multiple hidden layers that process the information and then lead to an output layer. I'm not going to go into that, but I just wanted to say that artificial intelligence may turn out to be a good double reader for us. So far, all the AI models have been created. None of them have an accuracy of more than 70%, but perhaps that's good enough to give us that double reading function. So that may be a moonshot for the next decade, to develop AIs that can do a reasonable job at being a double reader for us. We've had similar things. A computer-aided detection, which was basically a deep learning model, machine learning model, excuse me, that would look at mammograms, but it almost never found anything useful. It had a lot of false positives, and radiologists aren't too fond of it, but that was the past, and the future may be a lot brighter for artificial intelligence to help us with this problem. What's the magnitude of the problem? Well, there's about 1 billion radiology exams, and there's a 3 to 4% average error rate. So that means 30 to 40 million radiology errors occur every year. And there's good reason to think that most of these are undetected, because a good estimate based on the above is that that's maybe 700 errors per year per radiologist, because radiologists generally read about 100 cases a day. But my friends there at the Patient Safety Authority, based on the Act 13 reports, we're coming up with something more like 19 errors per year per radiologist. So that suggests that 97% of the errors that are being made are actually undetected, and probably most of them cause no actual reportable patient harm. But you know, we actually have a bigger problem with error than meets the eye. And it's a remarkably stable prevalence of error since 1945. And you know, that's despite tremendous advances in technology, massive increases in radiology and medical knowledge, despite being measured across a broad range of practice situations, and despite multiple generations of providers. From Dr. Garland, who first measured it, is no longer with us, and I was just a child when he died. So this has basically gone through many generations of radiologists. So to me, this suggests there may be an underlying biological or maybe a neurocognitive cause for human perceptual error. It goes beyond the kinds of things that we've done to fix it. And the mathematical physicist Leonard Mlodinow said that perception requires imagination because the data people encounter in their lives are never complete. They're always equivocal. There was always a high level of uncertainty. So I'm thinking that maybe a lot of what we consider to be error is simply a manifestation of the task's high level of uncertainty that's always dogging us. And I love this comic. You'll make the same foolish mistakes you have made before, not only once, but many, many times again. It's a pretty good prediction for radiologists and for everyone. So that's the elephant in the room. And how many legs does this elephant have, anyway? So anyway, we operate using biological tools, our eyes and our brain, that evolved under very different conditions and with a very different purpose than performing diagnostic radiology. So we developed some amazing abilities, but we also have some profound limitations. In terms of amazing abilities, radiologists will, based on eye tracking, we know they can find the abnormality on an image in less than half a second. And in fact, you can clamp their head. This was done. Clamp their head into place in a dark room and then flash a radiology image off-center in their peripheral vision for only 400 milliseconds, so less than half a second. So there isn't even enough time for them to turn their eyes to it, and they don't know when to expect it. And most of the time they can give you the diagnosis. It's amazing. But some profound limitations exist too. And if you look at this picture here, the classic, duck rabbit, it's possible to see this as a rabbit that's facing to the right of the screen or a duck that's facing to the left of the screen, but it's pretty much impossible to see them as a rabbit and a duck simultaneously. The New Yorker comics have also made a lot of ground with this too. I think everyone's seen this before, the Mueller-Lyra illusion. We know that both the central lines are the exact same length, even though the one below looks shorter. That's a neurocognitive illusion that we have. But you may not have seen this one. This is the shepherd's table illusion. It turns out both tabletops are exactly the same size and shape. And they sure don't look like it, but they are. And this one's a very famous one. Radiologists were told to look for pulmonary nodules on the CT image of the chest. Almost everyone saw the round nodule, which is seen at the bottom of the right lung, which is on the left-hand side of the screen, close to the edge of the dark air-filled lung, and almost every radiologist missed the black gorilla, which is next to the heart on the other lung up toward the top. And this actual test was given to a number of us who were examining for the American Board of Radiology in Louisville one year, and I'm hoping that I was in the control group because I did not see any gorilla. Now look at this image. About half of the people who look at this image see movement, and half don't. If you concentrate on the black dots, I think it also makes it more likely that you'll see a movement. Another strange feature of our visual system. This one's a great one. I love this one. This is known as the Fraser spiral. It really looks like a spiral. But in fact, it's just concentric circles. Now, even though you know the trick, it still looks like a spiral. There's nothing you can do to convince yourself that it's not a spiral. You trace your finger and you know it's not. So this is an illusion that's said to be cognitively impenetrable. Knowing about it is no protection. This is an example of eye tracking we talked about earlier, where a radiologist is looking at this chest x-ray, and you can see all the places where they looked, where their gaze were fixated, with how their gaze tracked from place to place in the image. And we know that the radiologist search patterns are fairly consistent, and usually they find the abnormality in less than half a second. But the gaze also tends to dwell on and also return to areas where lesions are present, even when the findings are undetected. So there's almost like the subconscious mind is seeing these things that the radiologist doesn't become aware of. And the eyes have looked at it. It's not that they didn't look at it. Like that example I showed earlier with the coin, if we had done eye tracking, I can guarantee you that the radiologist who missed the coin both those times looked at the coin every time. And for some reason, it just didn't register. And I put this slide in because radiologists have these amazing visual abilities to find stuff on images. So you'd think they would be good at visual puzzles like Where's Waldo, but they're not. Radiologists are no better than anyone else at finding Waldo. So let's talk about mechanism of perceptual error. And in our laboratory, we have a theory that we're working on. We're trying to get grant support to study it, that perceptual errors may represent a particular kind of random neurocognitive event, which psychologists have called mind wandering, but I think that's not exactly right in terms of what it should be called, but it's the closest. And then satisfaction of search may be related to something more like attentional capture, where having one abnormality on an image captures the radiologist's attention so much that they don't notice the other abnormality. And that would explain why sometimes it's the subtle abnormality that's picked up and the obvious abnormality that's missed, just because the attention was captured. So perceptual errors, they may occur because of natural spontaneous fluctuations in visual task engagement and attention. But for this explanation to be true, it has to happen without the observer's conscious awareness and without anything being recorded in their working memory. And I think all of us in radiology have had examples of errors that we've made. And I had one that was particularly inexplicable because I actually put an arrow on the finding, and then somehow it never made it into my report. So I actually saw the thing, recognized it, and somehow it did not get incorporated into working memory. That was when I was younger, so I can't say that I'm old and demented now. So, but anyway, an emerging literature on mind wandering, which the psychologists call this thing, it suggests that there's a particular mechanism, and it may be related to brain activation patterns. And there's a thing called the default mode network of cerebral activation. And that is that certain regions of the brain are active most of the time when you're at rest and you're not doing any task, and you're not really focused on anything. And it's thought to be related to your inward thoughts. And that's the default mode, and that involves a network of areas of the brain that are all active together at the same time. They're all connected together. And that subtends your sort of inward thoughts that happen most of the time. And there are other brain networks that are related to tasks. So the default mode network, or DMN, which was described by this guy Lee back in 2001, it appears to support self-directed thought. It's active at rest, and it's suppressed when you're performing a task that demands concentration. So if you look at those areas of the brain that make up the default mode network, they'll be very active when you're sort of sitting there waiting or thinking about something that's been on your mind. And then when you concentrate on something like you're reading a chest x-ray, all those areas of the default mode network switch off. And other areas of the brain that are involved in concentration, other networks like the frontoparietal network of concentration, the executive function networks, again, multiple areas of brain activity, all connected together, all start up at the same time. So it's kind of like a seesaw where one goes up, the other one goes down, and vice versa. And so there's a lot of literature on this, and the default mode network includes a few brain areas which are listed here. And if you're interested in this, there's a great paper which by Marcus Frischel here, and you can read up on that if it rings your chimes. It's sort of like your inner Woody Allen. You know, when the default mode network is activated, you might be having all your inner worries, and you know, your neurotic thoughts would all come through that. The frontoparietal network is believed to mediate your executive mental functions. Whenever you have a need for focused, externally directed attention. And it also recruits working memory. Remember, I mentioned that before. It includes different brain areas. And so there's a different cluster of brain areas that are activated when you're concentrating on something. That's sort of like your inner Mr. Spock. You know, it's doing the analytics and telling you that this is a very fascinating pattern, Captain. So experience sampling during functional MRI. Functional MRI is a technique by which we can look at regional brain activation. I won't go into the details of that. It's actually quite involved, but it's a great thing to understand if you're interested in this. But it's a way of looking at activation of different parts of the brain in real time, and you can have people doing things inside the magnet and see which parts of their brain are involved in those tasks. So mind wandering in this context, it refers to a specific mental state, and it occurs during a focused mental task where the suppressed DMN, remember the DMN goes down when you're concentrating on a task, but it doesn't necessarily stay down. It resumes spontaneously without warning and without the awareness of the person. And when that happens, it's highly associated with another phenomenon called perceptual decoupling, where the thought and the perception are not connected. And that would explain not only why things could be missed on images, but also why the person would have no awareness that they missed them. So it's a very attractive hypothesis for why this 3% stubborn error rate is being observed, even though we've changed everything, including the people involved. So it could be this co-activation of these two normally opposed brain networks. And when they're simultaneously activated, that is believed to produce this mental state where the resources of the focused attentional parts of the brain and working memory are essentially hijacked by the default mode network, producing an inwardly directed thought train. And it's probably a normal adaptive brain function that evolved over millions of years, but it's associated with this perceptual decoupling phenomenon. It's not under volitional control. It doesn't have any conscious awareness, and it can't be avoided by training or effort. So it may be a potential explanation for those attentional lapses that lead us to make errors. So remember, if Captain Kirk always had Mr. Spock to advise him, but what if he had, Woody Allen? It might not have turned out so well. And Aldous Huxley, I don't know if you remember him, he wrote a number of books, including Brave New World, which is very famous, and he famously tried LSD, and he wrote a book about his experiences called The Doors of Perception, and the rock group The Doors took their name from this book. And he talked about how when he took LSD, it was so wonderful that his annoying neurotic inner voice was silenced. And it turns out that if you take LSD, among the things that happens is your default mode network is completely shut off. And so it's very interesting that he described this neurotic inner voice, his inner Woody Allen, was silenced. So it's very interesting. So our core hypothesis in our research is that the DMN is generally suppressed and the FPN is highly active when we're looking at a chest X-ray. But while in task, the radiologist will unknowingly experience these episodes of spontaneous reactivation of the DMN, happens along with the FPN, produces a transient, very brief state of internally directed thought and perceptual decoupling, and that explains their perceptual error. So we're developing a series of experiments to look at that. This is the research team, along with me. I'm there on the right-hand side. So we go from the top. There's Dr. Chris Sathian, the chair of neurology at Hershey. Dr. Prasanna, who is our colleague, is actually a physicist by training, and he's an fMRI expert. Dr. Howard Egeth from Johns Hopkins, who's a perceptual expert. Dr. Elizabeth Krupinski, who is an incredible researcher who's done so much fantastic work over the decades. She's actually a PhD psychologist, a vision scientist, and almost everything we know about radiologists' eye tracking and performance and the efforts, the fatigue and all that stuff is from her research. Dr. Tim Mosher, who is my boss, she's the chair of radiology and very accomplished researcher. And then the last there is Dr. Brad Weibel from Penn State main campus, who's also a vision scientist there. And this is our core research team, and we've been working on this project. I'm going to, in the interest of having more time for questions, I'm going to skip the discussion of our actual experiments and but I want to show you this as our predicted time course of the default mode network activation. You can see the little brain there, and the functional fMRI image shows you activity in the areas of the default mode network, and we expect that the default mode network will rise spontaneously to a high level, and then when we start showing the radiologist images in the magnet and wanting them to make discriminating tests, the default mode network will go down and the frontal network will go up. So we expect that effect would change with the difficulty of the task and with fatigue. I'm going to skip over this because I think the details of the research aren't all that important to our discussion today, but this is some preliminary data, and we showed that was indeed the case. So this is actually my own brain. I was one of the 3 human subjects in the preliminary trials for our study, and I'm actually reading a chest X-ray at this very moment, and I don't seem to be having any mind wandering right then. So this is going to be a relatively rare phenomenon. And you can see activation in my visual cortex and in the areas of the frontoparietal network, but not in the default mode network at the time. So it doesn't mean I'm immune to this. It means we just didn't catch it. And part of the challenge of this research is we're looking for something that's relatively rare, something that occurs at the most 5% of the time. So it's going to be kind of challenging. It's sort of our moonshot here at Penn State Hershey and our sister centers like Emory and Johns Hopkins that we're all working on this together. I should move on to another area, a big area of error for us is cognitive bias. And that is, it turns out that people are irrational, and they're irrational in predictable ways. I don't know if you ever noticed that people can sometimes be irrational. And there's a number of biases that have been described, and they're of varying importance for diagnostic error. And anchoring bias, number 1, is a big one. You get stuck on something and you can't move out of it. You know, you're anchored. Another one is confirmation bias. You look at number 7 there in the middle of the screen. You can see the arrow going completely from ear to ear through the smiling face. We tend to listen to only information that confirms our preconceptions, and we discount information that contradicts our exceptions, and that's confirmation bias. Over 100 of these biases have been described, but anchoring and confirmation are really big ones in terms of medical error. Of course, number 12, overconfidence. Some of us are overconfident. The great physician William Osler said there's really only 2 types of doctors, actually, the overconfident and the underconfident. He didn't allow for any middle type. You know, about placebo effect and stereotyping and salience bias and things that are recent, and that pro-innovation bias, because that's why we have to have the iPhone 10, whatever. Our iPhone 6 just isn't good anymore because we have to have the newest thing. That's pro-innovation bias. All these biases have been well described, and they are a big contributor to error. And that brings us to the main point of my talk, what I like to call the Bruno 3-part error model. And that is that when we're looking at radiology errors, and really errors of a great many medical and other tasks, is we find they come down into 3 really distinct categories. Errors of how we work, and those would be system errors. And I'm a quality and safety guy, so I've been working on system errors pretty much every day, you know, for the last 15+ years. And those are, you know, errors of how we work, where we have faulty systems, and we have twisted incentives. We have things that lead us to use workarounds, and some of those workarounds actually have their own problems. And so those kind of system errors, we address them with quality and safety strategies like Lean and Six Sigma and management strategies, and we correct perverse incentives, and we you know, we deal with system errors at multiple levels. It actually tends, even though it's not a large percentage of errors in radiology, it gets a lot of our effort because it's something that we actually can fix in most cases. We can understand our systems errors and address them with PDSA cycles, and you know, we can deal with that. So you hear a lot about that aspect of error because, you know, when you have a hammer, you know, you go after the nails, right? So that's where we have our big effort, errors of how we work. Then there's errors of how we think, and that gets back to what I was just talking about with cognitive biases. those are our cognitive errors, and anchoring bias particularly, and confirmation bias. And the way to deal with those is using debiasing strategies. And it's kind of challenging to debias yourself. We're kind of stuck on our biases. So how do you debias yourself? Well, the very simplest debiasing strategy is to stop and ask yourself just a very simple question. What else could this be? Where else could this be? How else could this be? So what else? How else? Where else? What else? So that's debiasing, and that basically will help you deal with an entire large category of errors, errors of how we think. Finally, we get to the third category, and that's errors of how we are made. And that is what I've been talking about in the whole rest of the talk today. Is we have this visual, perceptual brain apparatus that goes from the surface of our eye all the way through the deep cavities of our brain. And we were made a certain way, and we were made that way for a certain purpose, and that purpose was not to do radiological diagnoses. And yet, with training, you can develop expertise that's just amazing, but you still are stuck with the basic apparatus, and we have perceptual errors and satisfaction of search, which end up being the largest error categories. They are errors of how we are made. They are poorly understood. And unless we do more basic research to understand them, we're not going to be able to come up with any strategies that really address this, and that's our largest category of error. So that's the elephant in the room, and hopefully our research will come up with something useful. So again, errors of how we work, faulty processes and workarounds, faulty policies and procedures, faulty technologies. Who's ever dealt with a faulty technology, right? EMR is perfect. Bad ergonomics, failed communications, and faulty organizational culture and faulty work culture, where people are maybe afraid to speak up and errors are hidden until they blow up. I mean, those errors of how we work, and all of these are amenable to good, rigorous quality and safety strategies and very aggressive management. The systems errors are cognitive biases, where our heuristics are wrong, where our reasoning is wrong, where we have incorrect knowledge or incorrect assumptions. Again, those are errors of how we think, and we can deal with them by debiasing. And finally, the errors of how we're made. Satisfaction of search is probably not what it seems. And for this entire class of error, double reading has been the only effective strategy, as Garland said. And one last thought, you've got to wonder if artificial intelligence really is the answer. Here we see a very happy robot, very gently handling an endangered species of butterfly, and of course, you may recognize the other artificial intelligence on the lower right-hand side of the screen. That's the homicidal HAL 9000 that killed everybody except for Dave in 2001: A Space Odyssey. So the truth probably lies somewhere in between. So I want to wrap up now. We have about 10-12 minutes for questions, and I would love to entertain your questions, and we can go into some greater depth. So I'm going to turn it over to Kathy.
Thank you, Dr. Bruno. That was fascinating. And right now, this concludes the slide presentation portion of our program. Now we'd like to begin our question and answer period. If you have any questions, please type them in the Q&A box found on the right-hand side panel of your screen and direct them to all panelists. We will try to get to as many questions as we can today live. However, Dr. Bruno has been gracious enough, if we have a lot left over, to be able to answer them, then we can distribute them to the responses to the registrants. So again, if you have any questions, please type them into the Q&A box on the lower right-hand side of your screen. While folks are getting their thoughts together, we do have some questions already, and I'll pose one to you, Dr. Bruno. So we talked a lot about double read, and so a question that comes up is, why not just have every radiology study double read by 2 radiologists then?
Well, that's a great question. It has been tried in some areas, especially in Scandinavia for mammograms. The main reason is that there aren't enough radiologists. Remember, there's about 1 billion exams, and there's only about 30,000 practicing radiologists, so it's really not possible. There aren't enough radiologists for every exam to be double read. We do have limited double reading, as I mentioned before, in academic centers where the trainees read the study the first time and the faculty read it the second time. But even in our center, we don't have enough radiologists to do that with every case like we used to. I mean, when I was in training, there were no cases that were not first read by a resident and then later read by an attending. 24 hours a day, 7 days a week, 365 days a year, every single study was double read. Our volumes are much too high for that now, and so the faculty do a lot of reading without residents just to keep up with the work. So the residents do as much as they can, and whatever they read, we also double read. That's the main reason. There simply aren't enough radiologists. Of course, the other side of this is that it would substantially increase the cost. You'd have to pay the radiologist to do twice as much work, and so the cost of every study would go up, and the costs currently are crushing. So so we don't have enough radiologists, and we probably don't have enough money for double reading. Someone suggested, well, why not just pick the ones that are more likely to have errors and double read them? Well, I think the reason that doesn't work is because errors really are truly random, at least the most important errors are. And so you can't know ahead of time which studies are likely to have errors and have only those double read.
Okay. Well, thank you very much. And we have another question here. Has there been any discussion that your hypothesis could apply to other healthcare providers to explain perceptual or cognitive bias errors?
Absolutely, yes. And I think it probably applies to lots of people. And I think it probably applies to TSA screeners. It probably applies to the people who fly, drones over Afghanistan and decide, who to blow up and who to leave alone. And there was it probably is a very generalized phenomenon that applies to everyone who has to make decisions based on visual, perceptual material, especially when they have to do it under some time pressure.
Yeah. And thank you for that response. Another question. Great talk. Even though it sounds like the only effective strategy to minimize diagnostic error, aside from fixing system problems, do you think it's helpful to work in any of this error classification content into peer learning / peer review conferences?
Oh, absolutely. And especially if we're getting over cognitive biases. I think that the pure perceptual error is hard to overcome with any kind of learning. It just seems to be biological. But there's some overlap between the error types, and the peer learning process is tremendously powerful. We're just starting it here at Hershey. We're sort of moving away from individually scored peer review to the open forum peer learning, where every error is analyzed and we try to figure out what caused it, what all the contributing causes were. And so I do think that has value.
Fantastic. Again, we've got great questions coming in, so continue to pose your questions here in the Q&A box on the right-hand side, and direct them to all panelists. I should add that. Another question. So what about computer-aided detection, CAD, in mammography, which has been in use since the 1990s? Why didn't that work?
Well, that's a good question. You can argue that it should have worked. It's actually the same artificial intelligence structure, like I showed in my earlier slide, that we're currently using for machine learning. Computers weren't as powerful back then, and so it wasn't possible to have as many sort of middle layers of processing, and so the computer-aided detection, even though it was a good idea, it was a little ahead of its time, and it just didn't work very well. It doesn't mean the concept is wrong. It just means that it wasn't ready for prime time. But unfortunately, the government decided that they would pay a premium if it was used. Someone just thought that was a great idea to use an unproven tool. They were going to pay an extra $5 or something. So everyone used it, and they sort of subjected it to ridicule because it utterly failed. But I think it was the reason that it failed was because it just wasn't, the computing power was just not strong enough, and so it had lots and lots of false negatives, and it only flagged findings that were easily seen, and radiologists really had the impression that it wasn't helping them at all, and they just went through the motions and gamed the system to get the extra $5, because why leave that on the table? And it sort of gave the whole field a bad stigma, that it was all a charade. But I think it's a very promising technology for the future.
Okay. And another question here. How do you score errors or discrepancies in place of the traditional scoring system? Example, RAD-Peer.
Yeah, we actually are in a hybrid system now where we still are using RAD-Peer through most of our department, and that scoring system is based on how conspicuous the finding is. So something that we think is fairly obvious, will get a higher score than something that's very subtle. It's based on sort of an older understanding of error, which I think is really not supported well by the science. We still are using it because we're trying to transition away toward a peer learning process where we just take every error and try to find out what we can learn from that error. So ideally, I think we would love to completely move away from scoring errors in any way and just use them all as learning opportunities. I think we would actually have greater performance improvement. And I say this in full disclosure, I am a member of the RAD-Peer committee. I was a member years ago, and I was a co-author on some of the RAD-Peer papers. But the truth is that RAD-Peer has been good for a number of things, but it hasn't really improved performance. There's really no data that show that it ever did, and so we're really hoping that the peer learning approach will actually result in improvement.
Okay, I think we still have time for another question or so. We had one come in. In terms of quality assurance, what should be included and analyzed to ensure you are capturing meaningful data for OPPE?
Well, that's a great question. I would like to say that we did put in the last RAD-Peer paper that the RAD-Peer score should never be part of OPPE, and that reflected the American College of Radiology RAD-Peer committee view that the score was not a meaningful, the score in itself was not a meaningful metric of performance. We have a number of things that go into ours. We look at report turnaround time because the quicker a report is produced, the more patients are served, the faster patients are served. We think that's a useful metric, and of course that we all have a sense that if you go too fast, you might make more errors. So there's probably an optimal level of report turnaround time. Getting it down to 500 milliseconds probably isn't a realistic goal, but you don't want it to be like 2 days either. So when I started this business, we had a report turnaround time that was measured often in days because a human transcriptionist would often be a day or two behind. But in those cases, we would have a verbal communication with the doctors that was more prompt. Report turnaround time, participation in departmental improvement projects and that sort of thing, citizenship, a number of things get put into OPPE, but getting to I think what the core of the question is, the error rate as measured by things like RAD-Peer is generally not considered a factor. Research shows that we all have about the same error rate.
Thank you for that. Don't see any additional questions coming in right now. I do, however, in my opinion, think that this has been a great talk, and I think we'll continue to drive a lot of conversations among folks, so even at the facility level. We do know that improving the diagnostic process and diagnostic errors are very much sensing topic right now, and we're seeing a lot of conversation across PA, so that's exciting. I want to thank Dr. Bruno for joining us this afternoon, and I want to thank everybody for joining us, and this concludes our webinar. Thank you.
Thanks, everybody.